Good morning, everyone. Good morning, everyone, and thank you for joining us. And we will get started this morning. This morning we have Dr. Rajesh Pahwa, who is joining us to speak on the non-pulmonary radiologic manifestations of COVID-19, the topic of the hour. And so Dr. Pahwa is a consultant radiologist at Doctors Hospital. He has a diplomate of the National Board of India, which is on radiologic diagnosis, a European diploma in radiology, a diplomate of the Indian College of Radiology and Imaging, and he has been practicing here with us in the Bahamas for the last 4 years. So let's welcome Dr. Pahwa. Thank you very much, Dr. Pahwa. And please be reminded, you can post your questions in the chat and we will post the feedback link in the chat. Thank you.
Good morning, everybody. So my presentation today is about non-pulmonary manifestations of COVID-19. I have no financial disclosures or conflicts of interest with the presented material in this presentation. So let's start with how the COVID-19 affects the cells, and that it affects the cells by binding to the ACE receptor and then damages the cells after endocytosis. Therefore, the presence of ACE receptor in the tissue is very important for the viral cellular tropism in humans. And ACE receptors are expressed in abundance in type 2 alveolar cells. Therefore, lungs are predominantly affected. But ACE receptors are also expressed in enterocytes, brain endothelial cells, glomerular endothelial cells, cardiac cells, brain parenchyma. Therefore, there are extrapulmonary manifestations as well of COVID-19. Though there is a direct injury to the cell, but yes, the hyperimmune response evoked by this virus when it interacts with the immune system leads to cytokine storm and releases various inflammatory mediators, which causes indirect injury to the cells as well. Now, considering the broad spectrum of the clinical manifestations and the increasing worldwide burden of the disease, and since the disease is still evolving, there is an urgent need to rapidly scale up the diagnostic capacity to detect the COVID-19 and its extrapulmonary manifestations. Coming to gastrointestinal manifestations. The large amount of ACE surface expression in the enterocyte of the gastrointestinal tract and to the lesser extent in the biliary epithelium has been offered as a possible explanation for gastrointestinal symptoms and liver injury. However, the gastrointestinal symptoms can be due to drug toxicity, systemic inflammatory response secondary to pulmonary infection. In various studies, gastrointestinal symptoms are described in significant number of COVID-19 patients. In one of the study in China, where 4,243 patients were studied, 18% of the patient had gastrointestinal symptoms. In a UK study, on 8,605 admitted patients, 29% of all the patients complained of entering symptoms, and it is interesting to know that only 4% of patients had only entering symptoms with no pulmonary symptoms. And similar findings were studied by one of the President Penn et al. In China, where gastrointestinal symptoms were the only presentations without respiratory abnormalities. So various gastrointestinal symptoms which are there consist of diarrhea, bloating, abdominal pain, anorexia, heartburn, burping, nausea, vomiting. So this is the comparative analysis of the different studies describing the gastrointestinal symptoms. As we can see, diarrhea is the most common presentation, followed by nausea and vomiting. But there is a study conducted by the Pan et al. Where anorexia was seen as a common gastrointestinal manifestation. Diarrhea, which is most common manifestation, can be explained due to the malabsorption of the infected enterocytes. There is a study conducted on 67 COVID patients with diarrhea, and they found that 13 patients had no other manifestations. So again and again, there are studies coming where COVID patients presents only with the gastrointestinal symptoms without pulmonary symptoms. They also, in a similar study, the Zhang et al. Also detected viral nucleic acid in the anal swab and fecal samples of the hospitalized patient, therefore suggesting alternate fecal-oral transmission as a route for COVID-19 spread. There's another study conducted on COVID-19 patient to study the positive RNA in the stool. So they found positive RNA in 53.4% of the patients between 1 to 12 days, and the stool was positive even after the respiratory swab was negative. So that gives us a new thought that it's possible that the rectal swab can also play a role in establishing the virus clearance from the body. But still, there is no confirmed analysis which exists, and more studies are needed. There is this large study on 412 patients published in Radiology journal describing the imaging findings in COVID-19 patient. Of all the right upper quadrant ultrasound performed, gallbladder bile stasis is seen in 54% of examinations. Bowel wall abnormalities ranging from diffuse wall edema, maybe air cyst in the wall like pneumatosis intestinalis, was seen in 31% of CT images. This is important to note that in ICU patients, 20% of the patient was detected to have signs of late ischemia with pathological correlation of the small vessel thrombosis. However, the number of patients of the studies were just 2.7% of the total patients. But yes, this is the important finding which needs recognition. So over here, we have a CT scan showing non-specific mural edema of the transverse and descending colon, and which are seen in a collapsed state. So it is a non-specific colitis seen in a COVID positive patient. This is another patient where we can see there is a non-specific pericolic fat standing in the ascending colon, and as well as there is a fluid distended ascending colon. So this finding is described in literature in patients who presents with diarrhea. We can also see there are some parenchymal changes in the lungs under view. So this is another patient who presented with abdominal pain and diarrhea, and there we can see the fluid distended rectum, the fluid distended descending colon, and there is this interesting finding of diffuse gallbladder wall edema, which is reactive cholecystitis, or you can say is a feature of a gallbladder bile stasis. And this is normally seen when there are inflammatory changes in the liver. So here we can see there is a fluid distended small bowel loop with diffuse mural thickening as well as mesenteric standing and minimal free fluid. And we can also see a little bit of clustering of these bowel loops over here. So these are not very specific, but these can be the signs of early ischemia. And since in many studies, there is a pathological correlation of microvessel thrombosis, so this is a possibility which needs consideration. Another study where we can see there is small cyst along the wall of the small intestine. So, which is described as pneumatosis intestinalis in radiology, and which is a feature of necrotizing enterocolitis. This is another case where we can see there is a non-enhancing wall outline of the small intestine, suggesting ischemic bowel changes. And then there is a frank discontinuity of the small bowel loop over here, suggesting perforation. And then this is again the feature of pneumatosis intestinalis. The laparotomy was performed, and we can see there is some abnormal discoloration of the small bowel loop. These are the cases which I picked up from the studies. These are not from doctor's hospital. These are from the studies. So this is another patient with an ultrasound of the gallbladder showing diffuse wall edema with stasis, seen as hypoechoic biliary sludge in the gallbladder lumen. So it's important before I go to the next system, it's important to mention about the inflammatory bowel disease, which is a comorbid condition when it comes to COVID-19. And these patients are more susceptible to COVID-19 infections because they are on biologicals and immunosuppressive drugs. International organizations such as Crohn's and the Colitis Foundation and the International Organization for the Study of Inflammatory Bowel Disease had issued helpful resources about IBD medications. At present, the recommendations is to encourage the patient to stay on the IBD medications such as immunosalicylates. However, reducing the dose of steroids is suggested by this international organization with a dose of 10 milligram or above once daily to avoid adrenal insufficiency. There is also a recommendation by the joint gastrointestinal societies about the gastrointestinal procedures. So they recommend considering rescheduling of the non-urgent endoscopic procedures, as these procedures are considered aerosol generating. However, the urgent procedure should not be delayed, such as for the treatment of gallbladder gastrointestinal bleeding, esophageal foreign body impaction, endoscopic retrograde cholangiopancreatography for acute cholangitis, endoscopic ultrasound drainage for the symptomatic pancreatobiliary disease, and for the palliation of gastrointestinal obstruction. Let's come to pancreatic manifestations. Again, the pancreatic injury in COVID-19 might be caused by the direct viral involvement or secondary from enzyme abnormalities in the context of severe illness. So COVID-19 patients can present with acute pancreatitis, and at present, the etiopathogenesis is not clear. A total of 17% of pancreatic patients in the analysis were positive for COVID-19, indicating that pancreatitis should be included in the list of gastrointestinal manifestations of this viral infection. The study on there was this study conducted on 67 patients with a severe COVID-19, and they found that 11 patients had elevated levels of both serum amylase and lipase, and 5 of these patients also showed imaging alterations. Whereas when it comes to the mild COVID disease, the only one patient had both amylase and lipase elevated. 1.85% of the patients, that constitute 54 cases. So without any imaging changes. So it's important to recognize that this is the pancreatic injury do exist in patients with COVID-19. It's possible that it would be subclinical in mild cases, and it would be frank pancreatitis in severe cases. So it's important that the pancreatitis should be paid attention in the clinical work. This is the same study describing the various parameters of amylase, lipase, and the imaging alterations. So this is a CT abdomen image where we can see there is a peripancreatic fat stranding around the tail of the pancreas, and as well as there is some fluid around the tail of the pancreas. Let's come to the liver manifestations. Elevated levels of liver enzymes is seen in many cases with COVID-19, and the in hospitalized patients, it is seen that 14 to 15% of the patient had deranged liver enzymes. The decline in the albumin level is also considered as marker of disease severity as described in different studies. And also the raised transaminase also have the same predictive value. On histopathology, moderate microvascular steatosis, mild lobular and the portal inflammatory activity was detected. Again, the liver injury can be caused directly by the virus or through the hyperimmune response, or also by the drugs which are administered to the patient for treating COVID-19. In this large study on 2,273 COVID positive patients, they found that 45% patients had mild disease, 21% of the patient had moderate disease, and 6.4% of the patient has severe disease. This is another analysis done where they found the acute liver injury was significantly associated with elevated inflammatory markers including ferritin and IL-6. So here comes the importance of doing this marker in patients with a severe COVID-19 disease. They also found out that they also expressed that the peak ALT was significantly associated with death or discharge to hospice after controlling age, body mass index, other comorbidities like diabetes, hypertension, intubation, and the renal transplant therapy. There is no imaging correlate of most of these findings in medical literature till now. However, the CT and the ultrasound features of the hepatic steatosis can be expected in patients with COVID-19 associated liver injury. So here we can see there are some parenchymal opacities in the lung, and the liver is showing hyperdense appearance, suggesting hepatosteatosis. There is this another case where we can see there is an extensive involvement of both the lungs, and the liver is showing heterogeneous hypodense appearance, suggesting hepatosteatosis. And also we can see there is some pericholecystic fat stranding in this case, which is a reactive phenomena caused by the inflamed liver parenchyma. Let's come to the neurological manifestations of COVID-19. So COVID AC receptors are expressed in different parts of the brain parenchyma as described in this image. The viral neuroinvasion can be direct transsynaptic transfer across the infected neurons, where they gain entry into the olfactory nerves via retrograde route across the cribriform plate of ethmoid bone. However, they can also reach the neural parenchyma after crossing blood-brain barrier, and they gain access to the blood after crossing the respiratory epithelium. So here we can see how the virus can travel across the cribriform plate and then infect the olfactory tract. And here's the diagrammatic representation how they crosses the respiratory epithelium, goes into the blood-brain, into the bloodstream. Then after crossing the blood-brain barrier, causes encephalitis, the leptomeningitis. This was described by the Juvener et al. In JAMA Neurology Journal. Though there are also other mechanisms of attack on a CNS, which includes cardiovascular endothelial rupture caused by virus infecting the endothelial cells, and which lead to intracerebral bleeding and further fatal complications. The hyperimmune response causing cytokine storm and the para-infectious immune-like changes as seen in the ADM. In other viral illnesses, hemorrhagic stroke and microbleed, which is mostly iatrogenic, but it can also be because of the isolated thrombocytopenia seen in many patients with COVID. Hemodynamic, thromboembolic, or the cardioembolic strokes, out of which the hemodynamic strokes are most common. This is a slide showing the comprehensive mechanism of attack on the CNS. So there is this retrospective observational case series done on 214 patients, and they found out that 36% of the patient had neurological symptoms, ranging from specific symptoms like loss of sense of smell or taste, myopathy, stroke, or non-specific symptoms like headache, which was the most common, low consciousness, dizziness, seizures. Another study described few more non-specific symptoms consisting of delirium, confusion, agitation, altered consciousness, depression, anxiety, insomnia. And it still remains unclear which of these features are due to the critical illness-related encephalopathy or the drug-induced encephalopathy, or it's because of the pro-inflammatory cytokine release or withdrawal or effect of the medication, or it's because of the COVID virus mediated direct cell injury. This is another study conducted on patients with COVID-19 with severe 19 with a severe disease and who experienced already the ARDS. And they described the neurological symptoms are more common in a COVID-19 patients with a severe disease than in a patients with a mild disease. And the neurological symptoms are also of severe nature, including encephalopathy, prominent agitation, confusion, cortical tract signs. Now, let's come to the anosmia and the ageusia, which is the common feature present in COVID-19 patient. It is described with a different frequency in literature, ranging from 5.6 to 19.4 to 80%. And it is described that there is a complete resolution or improvement after 4 weeks in 80% of the cases. Imaging is not required if this is an isolated symptom. This is an interesting case published in a neurology journal, which showing gyrus in signal changes in the gyrus rectus in patient with anosmia, with complete resolution of these signal changes after 20 days of onset of the symptoms. Another common but non-specific symptom is a headache, which is seen in almost 1/3 of the patients. The headache in COVID-19 patient is moderately severe, bilateral with a pulsating or the pressing quality in the temporoparietal forehead and the periorbital region. It is sudden to gradual onset, and mostly this poor response to the common analgesics. Now, pathophysiological mechanisms suggested in different articles consist of activation of the peripheral trigeminal nerve endings by the COVID-19, or it's because of the vasculopathy, or it's because of the increased circulating pro-inflammatory cytokines and hypoxia. Imaging is generally not required unless patient has neurological deficit or features of encephalopathy. Now comes to the stroke and the vascular events in COVID-19 patient. They are seen in 2.5% of hospitalized and emergency patients, and the most frequent type of stroke is the ischemic stroke. Risk factors such as older age, severe COVID manifestation, additional vascular risk factors, high C-reactive protein levels, and D-dimer levels increases the chances of stroke. There is at present no causal relationship between the COVID-19 and the ischemic stroke, but it is observed that it is seen more in COVID-19 patients compared to influenza patients. Pathophysiology is multifactorial, could be because of the elevated inflammatory markers, could be because of the infection of the endothelial cells, And as COVID-19 patients have hypercoagulability state, so they are clot forming, and which can lead to ischemic stroke. The strokes can be large territorial infarcts. As we can see over here, there is a complete occlusion of right MCA, causing large right MCA stroke. And there could be multi-territorial small peripheral infarcts distributed widely in both the cerebral hemisphere. We can see these small hyper intensities on a diffusion study showing restriction, which are consistent with the small embolic strokes. It's possible that diffusely atherosclerotic neck vessels are responsible for releasing small thrombi, and which are further which further cause this microembolic strokes. As we can see, the patient had extensive pulmonary disease as well. So there is this another study conducted on COVID-19 patients with a severe infection requiring hospitalization and oxygen therapy in France, describing the imaging findings in these patients after excluding infarcts and the cerebral venous thrombosis. So there are the three patterns which were seen that is medial temporal lobe abnormalities, multifocal white matter signal changes or hemorrhages, extensive or the isolated white matter microhemorrhages. The mechanism of the brain abnormality is still largely unknown. Only one patient was positive for RNA and CSF, which was not statistically accurate to call that it is because of the COVID-19. So in this 58-year-old male with a severe COVID infection and the impaired consciousness, we can see there is some hyperintensity in the medial temporal lobe. However, this is non-specific and can be seen in herpes, neurosyphilis, and Whipple's encephalopathy. So here we can see there are non-confluent multifocal white matter lesions in the bilateral middle cerebral peduncle, in the deep cerebellar hemisphere along the corpus callosum, as well as the deep white matter of both cerebral hemispheres. So this was described in patients with a severe COVID-19 infection, 65-year-old male with a pathological weakness after sedation. But again, these are non-specific, and they are similar to parainfectious immune disease, ADEM, which is also observed in other viral infections as well. And another pattern is the extensive and the confluent multifocal white matter changes, as we can see over here. And on this image, on the left cerebral hemisphere, on this image, it's bilateral. And also there was some sulcal enhancement. Again, these findings are though described in COVID-19 patient, 71-year-old male with a pathological weakness after sedation. But again, we can see these findings in viral encephalopathy, metabolic and toxic encephalopathy. The extensive or isolated white matter microhemorrhages, as we can see these small hypointense areas on a susceptibility images of the brain in 55-year-old male on ECMO, and which is seen in the COVID positive patient. But yes, we can also see these findings in high altitude cerebral edema or thrombotic microangiopathies. So let's come to cardiovascular manifestations. So COVID virus has a potential to infect the cardiomyocyte, parasite, and fibroblast via ACE pathway, leading to direct myocardial injury. But still, the pathophysiological sequences remain unproven. The COVID-19 virus can also affect the endothelial cells of the coronary vessels and therefore causing the diffuse endothelial inflammation, which in turn leads to instabilization of any pre-existing coronary plaque mediated by the inflammatory process, which leads to consequent rupture of the fibrous cap, exposing the thrombotic material and therefore causing the thrombotic occlusion of the vessel. This is proposed in various journals as a possible pathogenic hypothesis for acute coronary syndrome seen in patients with COVID-19. However, the myocardial injury can also be caused by the cytokine access and or antibody-mediated mechanisms. So this is the diagrammatic representation of how there is a direct or the indirect mechanism of action of the cardiac injury. As we all know, troponin is a representation of the cardiac injury in the serum. And in various studies, this is increased levels of high sensitivity troponin is seen to correlate with the disease mortality and severity in COVID-19 after controlling other comorbidities. In the meta-analysis of 341 patients with the cardiac troponin levels are significantly increased only in patients with the severe. If you see, there's a study which shows that in severe patients, the troponin levels were significantly increased. And troponin levels of more than 0.05 nanogram per liter were predictive for the mortality. It was observed that non-survivors offered a higher levels of troponin elevation, which continue to rise until that, whereas survival the troponin levels remain unchanged. So there is a significant correlation between the patient age, male gender, high anti-pro-BPN levels, high troponin levels, elevated serum creatinine, underlying hypertension, history of coronary heart disease, and a critical COVID-19 status with the chances of cardiac injury. The mortality rate is mostly associated with acute myocardial infarction, acute myocarditis, and the rapid onset of heart failure in COVID-19 patients. Now, arrhythmia is described in many studies as the first presentation of COVID-19 in almost 7% of the patients. And it is more common in the ICU patients than in non-ICU patients. It can be because of the electrolyte imbalance, but yes, patient also experiences high inflammatory stress, which can lead to these arrhythmias. On imaging, mostly the cardiac complications can be seen as cardiomegaly and a pericardial effusion. As we can see in this CT image, there is this sliver of hypodensity seen around the heart, which is pericardial effusion. And in the lung window, we can see ground glass opacity suggesting COVID-19 infection. Since the pericarditis and the myocarditis is described in literature, MRI is the best modality to assess it. So there is this study conducted showing epicardial and the intramyocardial enhancement on a late gadolinium study suggesting involvement of the myocardium in a patients with COVID-19. And in various studies, myocarditis was suggested as a plausible explanation for sudden cardiac death and other complications or other cardiac complications. Now come to the vascular part of the cardiovascular manifestations. There is a predisposition for thromboembolic disease in patients with COVID-19, which can be explained by the prolonged immobilization or viral-driven hyperinflammation with cytokine release leading to vascular inflammation or the hypercoagulable state with propensity to DIC. There are evidence for the thromboembolic disease as described in different literature. It is observed that high level of D-dimer is seen in severe COVID disease compared to the mild COVID-19 disease. And markedly elevated D-dimer was seen in non-survivor of COVID-19. D-dimer level of more than 1 milligram on admission was significantly associated with the hospital death. So it's very important to measure the D-dimer of the patients with COVID-19. So the respiratory failure in COVID-19 patient is not only driven by the ARDS, but also by the thromboembolic phenomena. And there are various studies describing the autopsy and the pathology findings, where they found the very high incidence of pulmonary embolism, or the thrombus in the deep veins, as well as the thrombus of the prostatic veins. CT image showing the hypodense thrombus in the right main pulmonary artery and the descending left pulmonary artery. And we can see there is an extensive involvement of the lung parenchyma in this patient. This is the feature of pulmonary embolism. So there is this another phenomena which is described in various studies, which is known as microvascular dilatation sign, where they describe the dilatation of a peripheral subsegmental pulmonary artery within the lesion of COVID-19. This is the ground glass opacity, which is presumed to be because of the COVID-19 pneumonia. And then there is this dilatation of the central vessel. When it's more than 3 centimeter, we call it microvascular dilatation sign. So in one of the study, they described that it's possible that this sign is because of the thrombosis occurring in the peripheral pulmonary artery circulation in the absence of apparent embolism. So it's important to mention about the Kawasaki disease, which is vasculitis of medium and small vessels, and it is mostly seen in children and has a predilection for involvement of the coronary arteries. So in an Italian study, there was 30-fold increase incidence of the Kawasaki-like disease observed in children who presented with a in a children with a COVID-19 positive status and higher rate of cardiac involvement. So after this, they raised a suspicion that it's possible that the COVID, there is some association between the high incidence of Kawasaki disease in severe form of COVID-19. And since April 2020, in various articles, there are rare cases of Kawasaki-like disorder has been reported in critically ill children with COVID-19 positive status. However, the true causative association between the COVID-19 and the Kawasaki disease has not been established as yet. But yes, this is an observation which is described in different articles. Now comes to the renal manifestations. 0.5 to 19% of the patients with the COVID-19 may demonstrate some degree of renal dysfunction, as described in different studies. The renal tropism is a potential explanation of commonly reported new clinical signs of kidney injuries in patients with a non-critical COVID-19 infection. So it is important to understand that it's not only the patients with a severe COVID-19 patients who has where there is acute kidney injuries, but also patients with a mild COVID-19 infections are also showing some level of renal dysfunction. Out of 236 ICU COVID patients, 78 developed acute kidney disease, and 35% of the patient needed a dialysis, as described in the study conducted in New York on 236 ICU patients. So again, the renal injury can be multifactorial. It can be direct invasion of the virus into the endothelial cells, so the podocytes, location of the proximal tubular location of the ACE receptor, or it can be indirect because of the hyperimmune response or because of the multiple failing organs. So it's important to know that the impaired renal function increases the patient's susceptibility to contrast-induced nephropathy. So before we advise contrast enhanced imaging studies in patient with COVID-19, though the patient is young and we presume that the renal function would be normal, it is a good idea to perform the renal function before administering contrast in these patients. So so there is this study published in Radiology journal describing pulmonary, cerebral, and the renal thromboembolic disease in one patient. So it's important to understand this aspect also, that though these disease can affect one organ in isolation, but yes, there are studies showing multi-organ damage in one patient. So here we can see there is a pulmonary embolus in the right pulmonary artery bifurcation. There is a complete occlusion of the basilar artery. And then there is a thrombus in the left renal artery causing infarct of the upper pole of the left kidney. In various studies, the adrenal complications were also reported, though rare. But if patient develop bilateral adrenal hemorrhage, that's a very serious complication. So it's important to recognize this. On CT, it is seen as enlarged non-enhancing adrenal glands. There's another study also showing the bilateral adrenal hemorrhages. As we can see, there is a patchy enhancement of the adrenal glands and some hyperdensities, and there is a bilateral enlargement of the adrenal glands. Also reported in one of the case, the adrenal infarction, possibly because of the thrombosis of the microvasculature. And as we can see over there, there is a non-enhancing adrenal glands with mild locoregional fat stranding. Now comes to the hematological, immunological manifestations. Till now, I said it many in multiple slides. I described that there is a hyperacute immune response which causes the cytokine storm in COVID-19 patients. So it's very important to know that these patients can also develop the hematological features such as early onset of normal or decreased white blood count or decreased lymphocyte count. And in various studies, it is described that the lymphopenia may be the predictive for the progression of the disease. And in one of the studies, it is described that the lymphopenia of less than 1500 is seen in 100% of the severe COVID-19 patient. There is also growing evidence for the transient depletion of the T cells as well, especially the reducing CD4 and the CD8 T cell count upon admission was predictive of the disease progression in one of the large study conducted by the Zhang et al. So this disease is evolving and there are new features which are coming up and new observations which are described in different literature. We need to recognize this. Another common hematological manifestation is a isolated thrombocytopenia, which is reported in the COVID-19 patient, which can lead to low extremity purpura, epistaxis, and in few patients, the neurological symptoms like headache, which can be attributed to the microhemorrhages in the head CT. Now comes to the lymph nodal involvement. Mediastinal lymphadenopathy is seen as a common finding in critically ill COVID-19 patients. And this lymphadenopathy, since it is reactive in nature, should not be considered as an atypical feature of COVID-19. And mostly these lymph nodes are well-defined, they are discrete, with no areas of necrosis or calcifications. So here is a CT image showing these lymph nodes, and on the lung window we can see multiple parenchymal changes. It's important, as I already mentioned, the interleukin-6 level is associated with the severe liver injury. So in many studies conducted, and interleukin IL-6 levels is considered. Monitoring of the IL-6 level is now a standard practice in various places, where they after observing the fact that there is a decrease in IL-6 level, and which decides the effectiveness of the treatment, and there is increase in IL-6 level when there is a disease exacerbation. And high levels of IL-6 and IL-8 during treatment were observed in patients with a severe and the critical disease, and is correlated with the decreased lymphocyte count in about 326 patients, as described by the Zhang et al. Now comes to the cutaneous manifestations. According to recent studies published about the skin manifestations of COVID-19, it is described that the patients with the confirmed COVID-19 infections may present with a cutaneous involvement. So the Galvin described the 5 clinical outcomes of the lesions. That is, the acral areas of erythema with vesicles or pustules, called as the pseudo-chilblain lesion in 19% of the patients, maculopapular eruptions in 47% of the patients, other vesicular eruptions, and urticarial lesions. Now, the vascular eruptions are generally observed early in the course of disease, even 15% before other symptoms, whereas this pseudo-chilblain lesion pattern was frequently seen in the late evaluation of the disease. It was also noted that skin lesions are mostly not or slightly itchy, and the area of presentation is mostly the trunk of the body. There is this another interesting feature which is described in literature called COVID toes, which are the chilblain-like lesions which mainly occur at the acral areas. They are sometimes itchy, sometimes asymptomatic, and it is proposed in a different articles that it's possibly because of the micro thrombus causing the ischemias of the small vessels, or it could be because of the inflammatory response which is causing the symptoms, and it's normally seen in as a late manifestation of the COVID-19. And there are 3 cases of COVID-19 described in this study by the Martin, where they described the ulcers in oral cavity with pain, discomitative gingivitis, and the blisters. This is again a picture showing different skin manifestations. Now comes to the ocular manifestations. According to American College of Ophthalmology, conjunctival injection and chemosis are amongst the extra pulmonary manifestations of COVID-19 infection. Ocular manifestations in COVID-19 are currently self-limiting, and there are no reports of sight-threatening manifestations of COVID-19. Also, in this study by Wu described the positive PCR results from the conjunctival swab. So it's we still don't know, but yeah, it's possible that the virus is excreted by the conjunctiva as well. So there is another study where they saw the retina can also be affected, as shown using the optical coherence tomography, which is a non-invasive imaging technique that is useful for demonstrating subclinical retinal changes. So 12 adult patients showed hyperreflective lesions at the level of ganglion cells in the inner plexiform layers, more prominently at the papillomacular bundle in both eyes. And it's important to note that the ocular side effects of the drugs used for the treatment of COVID-19 are also seen. Like antimalarial drugs, antiviral drugs, and the immunomodulator drugs, they have potential ocular side effects. So this is the study showing the spectrum of ocular symptoms in COVID-19 patients. As we can see over here, the chemosis, apiphoria, secretion, and conjunctival hyperemia. These are the most common features. This is a patient showing the follicular conjunctivitis in COVID-19. Comes to the reproductive system involvement. Because of the high expression of the ACE expression in the human testes and uterus, the reproductive system may also be the target of COVID-19 infections. According to the data available and a few of the studies, orchitis is rare, but it's an important complication of the disease. There was this study published on a patient with COVID-19 who presented with the testicular pain, and after, and they described on histopathology, this patient died, and then the histopathology of testis was done, and there were some inflammatory cells were seen in the testis, though the clinical presentation of the orchitis was not very overt, but yes, on pathologically, there was some inflammatory changes in the testis. Now the COVID-19 and pregnancy. Recent research on the clinical characteristics of the pregnant woman with COVID-19 demonstrate that the clinical manifestations are similar to the non-pregnant adults, consisting of fever, cough. However, the pregnant women are more susceptible to COVID-19 and its complication, and may even progress to severe illness. There is no strong evidence of confirmed vertical transmission. However, mother-to-child transmission in COVID-19 or the SARS infection cannot be excluded. When it comes to the perinatal COVID-19, there are severe adverse effects on the fetus and infants are reported as fetal distress, premature labor, newborn respiratory disorder, thrombocytopenia associated with abnormal liver function, and even perinatal death. So there is this study conducted to compare the clinico-radiological features and outcomes in pregnant women with COVID-19 pneumonia compared with the age-matched non-pregnant women. So here we can see there were more ICU admissions and the length of hospitalization stay was longer. And on the initial CT imaging characteristics of the pregnant and the non-pregnant, comparing these, as we can see, the bilateral lung involvement was seen in pregnant women. More number of lobes were involved in pregnant women. The peripheral and the central opacities were seen in more number of cases as compared to the non-pregnant women, and the consolidations were more in patients with in the pregnant patients, and the pleural effusions was also seen in the pregnant patients. So it's important to understand this, that they are more susceptible to the complications of the COVID-19. So just one or two slides on the pediatrics. So there is an epidemiological peculiarity in pediatric patients, as described by the Zhang and 551 cases of the pediatric pulmonology journal, and as well as in some 421 cases in the pediatric radiology journal. So there is a male predominance, and 48% of the children were under 5 years of age. Family cluster infection was most common. So it is very important that as we know, the children are at home and they are not moving out, but it's the adults who move out and they bring the infection to the house, and the children are getting affected because of this. And the incubation period is less than 7 days. So there is this phenomena of multisystem inflammatory syndrome in children described in severe condition, though it's very rare, but yes, it is described in severe COVID-19 infection after 2 to 4 weeks. And the most common cases of this multisystem inflammatory syndrome has features of shock, cardiac involvement, gastrointestinal symptoms consisting of abdominal pain, vomiting, and diarrhea, and significantly elevated markers of elevation of the inflammations like IL-6, with positive laboratory test results for the COVID-19. Of all these patients, 565 patients who underwent testing, all patients are positive for RT-PCR or serology. So this is the important condition which we need to recognize. Like before, if the child presents with systemic features, it's important that the pediatrician or the primary care physician should take expert advice, and it's possible that this child might need a care in a pediatric ICU, and the child will can manifest the multisystem inflammatory syndrome. So to conclude, there are non-pulmonary manifestations of COVID which can present in isolation or can present with pulmonary manifestation. And as we know, this disease is still evolving, and it comes with many mysteries. So more studies are needed to actually understand this disease as a whole. And therefore, there is a need to recognize the manifestations early so that we can treat them and decrease the damage. And definitely, a special consideration is required while treating pregnancy and pediatric patients. So at last, at the end, instead of saying thank you, I just want to say, stay safe, stay vigilant. Thank you for listening, and I can now answer the questions.
Thank you very much, Dr. Pahwa, for describing from a radiologic perspective what we will see related to COVID-19 symptoms. One of our first questions is, what are some of the emergency radiologic findings related to COVID-19 that you have presented that we should consider or think about looking for in our patients who may present with symptoms pertaining to that emergency?
Okay, yeah, that's a really good question. So since as you can see, and even while I was going through these extra pulmonary manifestations, almost every system is affected. And so it's important to understand that the patients who present with the to the emergency can be a potential. Any patient who comes is a potential COVID patient. Now, the life-threatening emergencies which are there consist of, I would say, the cardiac and the neurological. So it is important to recognize them. And if you see a patient who presented with features of altered neurological status, it's important that we do a required blood work and measure the various immunological markers and perform an MRI or a CT scan on these patients, so as to understand what is, if there is any damage to the organs at present. And then second is the cardiac. Cardiac is also very important because the patient present with the non-specific symptoms, and which can be, one can attribute it to heartburn, could be acidity. We will just wait for the maybe definitely ultrasound is important to rule out if there is any gallbladder issues or if there is any abdominal issues. But it's very important to understand that if the patient is presenting with any features which is not directly showing the cardiac involvement, but they are indirect features, still we need to run the troponin levels, so that as in various studies it is shown that troponin is high in patients with the COVID-19, and it is associated with the mortality. And I would just request my radiologist friends in the group that we are doing the low dose CT scan in these patients. I know, so as to that serves two purposes, because patient undergoes multiple examination, the radiation is less, and secondly, since as I already told, these patients have subclinical renal dysfunction. So by giving contrast, we are putting a complete recipe for contrast-induced nephropathy. So even on even on a, I would say, low dose CT scan, if we can mention a little bit about the pericardium, whether there is a minimal effusion or not, though it is clinically insignificant, but if the patient has cardiac symptoms, the clinician can relate to it. Okay, this is there is some kind of inflammation which is going in the heart, which is causing this pericardial effusion. And they can further investigate the patient. But to actually diagnose myocarditis, we need MRI. So, but yes, there are, but we cannot perform MRIs on all the patients. Like the studies I've described, they are performed in only few patients, and it is very difficult to appoint the patient for MRI and then do all the COVID testing and so many things which goes into it. So this disease is something, it puts it to the brick wall. Like you want to do this thing, and then this thing says you can't do this. So it's important to recognize the early telltale signs and then deal with this. And I would say the brain and the heart, they are the two important areas with which one need to be very vigilant and very cautious, and try to go further with this. And whenever needed, require management need to be done in this area. It's important to recognize them early, because once the damage is done, then the patient is already into the severe COVID disease, and there is a multi-organ failure already occurring. It's difficult to bring back patient from there. So I'm a radiologist. I don't know how much justice I did to this question, and if you can please let me know.
Yes, and Dr. Kanye Farquharson actually highlights what you said, a very informative presentation. It expands the range of signs and symptoms to be aware of in the community setting, so that these things can be suspected a lot earlier. And so we have, thank you very nice from Dr. Santita Belgrave, Dr. Varunda Saka, from Dr. Tiagi. And Dr. Belgrade has a question. And so I may have to answer your question for Dr. Belgrade. COVID appears to be another great mimicker. What is your position on having either all patients or those with non-pulmonary manifestations tested prior to admission? Because I know where you work, all patients are tested for COVID prior to admission, versus at Princess Margaret Hospital, we're not there yet. But do you have any additional comments?
Yes, again, it's a really tricky situation. Performing a COVID-19 test is definitely important. But yes, there are different dynamics which goes into it. Sometimes it's not readily available, and if you go, it takes time for the results to come. So again, it's definitely patient to patient basis. If the extrapulmonary manifestations are such that they need hospitalization and they need due care within the hospital, and patient cannot be managed conservatively, yes, definitely we need a negative COVID test before we bring the patient inside the within the hospitalized patients. Yeah, but if it is a conservative management, and definitely if it is conservative management, and you can, again, it's a patient to patient basis, depending upon how the patient is presenting. You can treat the patient with a yeah. You want to say, Dr. Amala, anything?
No, I wanted to ask you, while you're there, before we got to the point of testing all admissions where you work for COVID-19, was there any patient that you're aware of who would have been diagnosed because they presented with what looked like an unusual presentation where COVID was suspected? An unusual radiologic finding outside of pulmonary?
I would say there was one patient which I remember, like the patients presented, the husband died of COVID-19 a month back. Patient presented with a diarrhea, simple diarrhea. There was no other feature. And when we did a CT abdomen, it was looking normal. The only finding which was there in a CT abdomen was a fluid distended colon. So that is a feature seen in any patient with a diarrhea. But when you look at the literature, diarrhea can be the only presentation, and the fluid distended colon can be the only feature on CT scan. So yeah, it's a difficult question to answer, and because I would say in the initial part of the disease, these non-specific symptoms were left to themselves, and many of them were self-limiting. So patient just improved and no one knew about it. you know. And what all studies I've seen, most of them are retrospective studies. So they were looking into the symptoms and then they were correlating with the COVID positive status, and then most of them are retrospective studies. So as you can say, I believe there are patients with a only non-pulmonary manifestations, but they are missed because it's a new disease to us and it's still evolving.
Okay, and that will take us into Dr. Halkidis's question. From March to now, based on your non-radiologic investigations being done, what is the emerging pattern of presentation in our patient population? Are we seeing more cerebrovascular accidents, myocardial infarctions based on radiology findings in these COVID-19 patients, or just in general compared to what you would normally see? I mean, are you able to comment on that?
No, because see, I am dealing with the radiology part of it. When the patient comes to us and we do a CT chest or CT abdomen and we just see that part. But definitely the complete picture of the patient, whether the patient died of the myocardial disease or the cerebrovascular accident, sometimes we don't get to know. But I would I would be really happy if someone in the attendees who has seen this, who is in an ER room or ER setting or maybe an ICU setting, can comment upon this for the benefit of everyone, because this is not something topic with one person, like related to one specialty. This is a complex topic, I would say, and complex presentation. So if someone can really enlighten on this, it would be really nice. Yeah, this part is difficult for me to answer.
Okay. And so we have well done, sir. And that's from Dr. Conville Brown. And great presentation as it relates to the neurological manifestations. Your presentation highlights the need to be hypervigilant, as cerebral ischemia is very common in our setting. And you actually mentioned that medial temporal lobe abnormalities were very common, or more
No, it's not.
common in the COVID-19 patients. Are we seeing more of those in terms of our CVA
See,
presentations from March to now?
okay. So it's important to, I think, in the presentation, the medial temporal lobe abnormality, which was seen in more of an encephalitis. So in that study, they excluded the stroke. So
Okay.
most of these patients were not, I would say, showing any diffusion restriction, which is compatible with the stroke. So the medial lobe and temporal lobe involvement, which was described in the study, is more of an encephalitis picture than a stroke picture. And till now, there is no, in my hospital, there was no patient with the medial lobe involvement. But yes, and it was, they described it in a patients with a severe infection who needed hospitalization and ICU admission. And because the patient was COVID positive, patient was hospitalized, there was this MRI feature of the medial lobe involvement. So on the basis of that, they are saying that it's possibly because of the COVID-19. However, this is also seen in the herpes encephalitis. This is a very classical picture. So when we see these hyperintensity in the temporal lobe, we immediately jump to the diagnosis of the herpes encephalitis. That's a radiological clear picture. But in COVID-19, it's a new thing which is coming up, that it's trying to mimic almost every disease. So yeah, but more studies are needed, I would say, to
Okay.
have the causal relationship.
So lots of thank yous, great presentation, Catherine Conliffe, Dr. Wallace. And we have a question, and I don't know who it's from, but most informative. Thank you, good doctor. Should recovered patients be re-evaluated radiologically, and if so, especially in what situation?
Interesting. Yes, yes, it's really interesting because there is this phenomena which is existing as a pulmonary fibrosis. So because my presentation was mostly on the non-pulmonary manifestations, but yes, There were a few patients who were treated at Doctors Hospital West in the earlier part of the disease, maybe in the April part, and they had extensive disease. And when we did a CT scan on these patients after a few months, there was this extensive pulmonary fibrosis. So in few patients, this disease leaves a scar in the lung and causes the extensive pulmonary fibrosis and decrease in the, I would say, the healthy lung. So because of that, these patients are prone to the reinfection as well. So it's important if the patient is presenting with the symptoms, we can reevaluate these patients. Yeah, but again, it's because we are still dealing with the patients with the fresh presentations, and there are a lot of them. So again, it's a decision to be made on the case-to-case basis. But yeah, it is useful to reevaluate the patients. It's useful.
Okay, and so that question was actually from Dr. Frankson. And Dr. Halkidas was saying that this is a very informative presentation and that it's a good, I have to go back to, I have forgotten it now, a good area to do research on and get the
Yes.
information and the sequelae of patients and those with the mild disease. So we have one more question, very informative. Based on ACE receptors and their position,
Yes.
like the fact that you mentioned surgeries should continue. Should surgeries continue? Okay. The question, for some reason, I don't think the whole thing came through. Based on the ACE receptors and their position, like the fact that you mentioned surgeries, should they continue?
Surgery.
Yeah. Dr. Monroe, are you there? Would you like to ask your question? I'm not too sure. I'm getting the sense of your question. Okay.
Yes,
Go ahead, Dr. Monroe.
Yes, please.
I'm just supporting the comment that he made that you should be discriminatory and discretionary in providing care to patients who have conditions other than corona in this time of corona. So I love the presentation, Dr. Powell. I think it was very, very scientifically based, and that's why I mentioned the business with the ACE inhibitors. I like the fact that you talk about the biologics of it, with the cytokine storm and how you manage it. There was only one other point when you mentioned about Crohn's and inflammatory bowel disease and the use of steroids, because they have had studies where they say steroids positive outcome in some of those patients. So again, I guess it comes down to discretion.
Yes. Yes.
Thank you very much for your comments, Dr. Monroe. And thank you very much, Dr. Power, for joining us this morning and for enlightening us on this well-prepared and researched presentation. And yes, it is the great mimicker. And as months go by, we're learning more and more. So thank you to everyone. And if you look in the chat, the link was placed for the feedback and the passcode or to claim your CME is radiology, all lowercase. We have 2 more CMEs left for the year, the second Wednesday of November and the last Friday. So everyone have a good day and thank you for joining us.
Thank you so much for attending this. And thank you, Dr. Amala, for giving this opportunity to me. And I'm also feeling good about this because of this, I learned a lot. Because I was presenting this, so I learned a lot while doing this myself. Yeah, thank you so much.
Thank you. Goodbye, everyone.